Good morning guys. Now I am going to present a lecture on dental implants and its anatomical landmarks. What is implant? Dental implant is a surgical component that interferes with the bone of the jaw or skull to support dental processes such as crown, ridge, denture, facial process, or to act as an orthodontic anchor. The basics of modern dental implants is a biologic process called osseointegration, where the materials such as titanium form and a intimate bond to bone. The implant fixture is first placed so that it is likely to osseointegrate, then a dental prosthetic is added. A variable amount of healing is required for osseointegration. Either the dental prosthetic is attached to the implant and or an abutment is placed which will hold the implant dental prosthetic. Indications: any edentulous area, severely morphologic compromised of denture supporting areas that significantly undermine the denture retention, poor oral muscular coordination, low tolerance of mucosal tissues, parafunctional habits, active or hyperactive gag reflexes, psychological inability to wear the removal process, unfavorable number and location of potential abutments in residual dentition, single tooth loss to avoid the involving neighbor teeth as abutments. Contraindications for dental implants: acute illness, terminal illness, pregnancy, uncontrolled metabolic disease, tumoroidal radiation, history of intravenous bisphosphonate therapy, unrealistic expectation, improper motivation, lack of operator experience, unable to restore teeth prosthodontically, inability of the patient to manage oral hygiene, patient hypersensitive to the specific components of the implant. Classification of dental implants: endosseous, subperiosteal, transosseous. Endosseous is divided into root form, blade form, ramus form. Subperiosteal is subdivided into complete, unilateral, circumferential. Transosseous is subdivided as stable, single pair. Endosseous implants: adequate bone to support the implant with width and height being the primary dimensions of concern, and maxillary and mandibular arch locations complete or partially edentulous patients. Ramus frame: adequate anterior bone to support the implant with width and height being primary dimensions of concern. Mandibular arch locations can be used. Completely edentulous patients. Subperiosteal: atrophy of the bone but with adequate bone to support the implant. Maxillary and mandibular arch locations. Completely and partially edentulous patients can be used. Stable bone for support. Transosseous: adequate anterior bone to support the implant with width and height being the primary dimensions of concern. For long-term successful performance of dental implants, types of general factors should be considered: biomaterials, biomechanics, dental evolution, medical evolution, surgical requirements, healing process, prosthodontics, and post-incision maintenance. Generally accepted implant success criteria: the individual unattached implant is immobile when tested clinically. No evidence of peri-implant radiodeficiency is present as assessed as an undistorted radiograph. The mean vertical bone loss is less than 0.2 mm annually after the first year of service. No persistent pain, discomfort, or infection is attributed to the implant. The implant design does not preclude placement of crown process with an appearance that is satisfactory to the patient and the dentist. This is the mean vertical loss of dental implant which is placed before 10 years. The mean vertical loss is less than 0.2 mm annually after the first year of implant placement. Osseointegration: the phenomenon of osseointegration of titanium implants was discovered by Swedish surgeon Brandmark in 1952. Function analysis: where new bone is laid down directly on the implant surface and the implant exhibits a mechanical stability. Success rate should be more than 90%. Histological dimension is direct connection between the living bone and the load-bearing endosseous implant at the light microscopic level. Factors affecting osseointegration are biocompatibility of implant material, implant design, surface condition, status of host bed, surgical technique, and implant loading. Fibro-osseous integration: the tissue to implant contact with the dense collagenous tissue between the implant and the bone, seen in earlier implant systems. Initially good success rate but extremely poor long-term success in terms of fibro-osseous integration, considered as a failure by today's standards. Implant component. Abutment, screw, interim abutment, implant body are the components of implants. Clinical implant components. Osseointegrate implant are generally designed to support screw and cement retained implant restoration. Implant body. The dental implant body are often referred to as a fixture. Is the component placed within the bone during the first stage of surgery. Type of root form of the implant body. Threaded root form, non-threaded root form. The main categories of implant body are titanium screw, hydroxyapatite coated screw, titanium plasma sprayed cylinder, hydroxyapatite coated cylinder. The types of root form of the implant body: smooth, machine, textured and coated. Healing screw. During the healing phase after the first stage of surgery, a screw is normally placed in the superior aspect of the fixture. The screw is usually low in profile to facilitate the suturing of the soft tissue in two-stage implant or minimize loading in at one-stage implant. In a second-stage surgery, a screw is removed and placed in the subsequent component. Interim abutment are dome-shaped screws placed after the second stage of surgery and before insertion of prosthesis. The abutment range in length from 2 to 10 mm and project through the soft tissue into the oral cavity. The abutments may screw directly into the fixture or in the other systems into the abutment immediately after the second stage of surgery. Abutments. Abutments are components of the implant system that screw directly into the implant. The abutments eventually support the prosthesis in screw retained restoration as much as they accept the retaining screw of prosthesis. For cement retained restoration, the abutments may be shaped like a conventional chrome preparation. The walls of the abutments are usually smooth, polished and straight-sided. The length range from 1 to 10 mm and in non-aesthetic area, 1 to 2 mm of titanium should be allowed to penetrate the soft tissues to maximize the patient's ability to clean the prosthesis. The choice of abutment size depends upon the vertical distance between the fixture base and the opposing dentation and the existing circular depth and the aesthetic requirements in the area being restored. For acceptance appearance, an anterior maxillary crown may require 2 to 3 mm of subgingival porcelain at the facial gingival margin to create the proper emergence profile and appearance, whereas the fixture in the posterior maxilla or mandible may have the margin termination at or below the gingival crest. Impression coping. Impression coping facilitates the transfer of a intraoral location of implant or abutment to the position on the laboratory cast. Impression coping may screw into the implant or into the abutment and are customarily subdivided into fixture abutments or abutment types. Types of impression coping: transfer, pickup. Implant analog. Implant analogs are made to represent exactly the top of the implant fixture or the abutment in the laboratory cast. Therefore, analogs can be classified as a fixture analogs and abutments analogs. Both the types of analogs screw directly into the impression coping. After it has been removed from the mouth and joined components are returned to the impression before pouring. Wax sleeving. Waxing are attached to the abutment by relating the screw on the laboratory model. The sleeves eventually become a part of the process. In non-segmented implant crowns, the sleeves are attached directly to the implant body analog in case of the cost. The prosthesis retaining screw. The prosthesis retaining screws penetrate the fixed restoration and are secured into the abutment. The screws are tightened with the screwdriver and attach non-segmented crowns to the body of the implant. Anatomy of dental implants. In 1988, Miss classified on classification of bone density. He classified it into the bone into the 4 groups of independent region of the bone based on the microscopic structure of the bone. D1 is a dense cortical bone, which is usually located in the anterior mandible and the posterior mandible. D2 dense to porous cortical bone surrounding dense trabecular bone, which is usually located on the anterior mandible, posterior mandible and anterior maxilla. D3 is a thin porous cortical bone surrounding the fine trabecular bone, which can be usually located on the anterior maxilla, posterior maxilla. D4 is a fine trabecular bone, which can be actually usually located on the posterior maxilla. D5 is the immature bone and non-mineralized bone. D1 is a dense cortical bone. Highest bone to implant contact can be present. Anterior region of the mandible, very dense compact bone. dense to thick porous cortical bone, and coarse trabecular bone is D2 bone, in which there would be a bone to implant contact of nearly about 70%. Dense to porous compact bone on the outside, and the coarse trabecular bone on the inside is present. Anterior to posterior, anterior and the posterior mandible will usually have a D2 type of bone. D3 bone is usually thin, porous, cortical, and fine trabecular bone, in which the bone to implant contact can be nearly about 50%. The thin, porous, compact bone and the fine trabecular bone is present anterior on the anterior or posterior maxilla or posterior mandible. The fine trabecular bone is the D4 bone, in which the bone to implant contact will be less than 25%. No cortical crystal bone is present, which will be usually present on the posterior maxilla in long-term edentulous patients. Anatomical limits for the implant placement. Maxillary anterior region, the low quality and the quantity as a bone height decreases the remaining bone, narrow to close approximation with the nasal cavity, maxillary sinus, and the incisive canal. It is limited to the canine eminence areas. Canine eminence area such as much suitable for the implant placement in the maxillary arch. Maxillary posterior region, due to the resorption pattern, the proximity of the sinus and the quality of bone implants are rarely placed here. The severe bone resorption and low palatal wall creates a different situation for implant procedure. Mandibular foramen. The location of the mandibular foramen may vary based on the race ethnicity, and this can affect the success of block injections. It is advisable to inject the patient 6 to 10 mm superior to the occlusal plane, which usually accounts for anatomic variation. This is the mandible foramen in the mandible. Inferior nerve canal. The trigeminal nerve, there is a fifth cranial nerve, has 3 main branches: ophthalmic, maxillary, and mandibular nerve, in which the mandibular nerve gives rise to the inferior alveolar nerve. The thickness of the inferior alveolar nerve canal is 3.4 mm wide and 2.2 mm thick. Within the canal, there is a nerve, artery, vein, and the lymphatic vessels. When developing an osteotomy over the mandibular canal, the cortical bone is penetrated first, and the preparation terminates within softer cancerous bone, and the mandibular canal usually has a cortical bone around it, which may provide some resistance to drilling. This is the inferior alveolar nerve canal. The inferior alveolar nerve may present in different anatomic configuration. The nerve may lower gently as it proceeds anteriorly, or there can be a sharp decline, or the nerve can wrap around in catenary fashion. The inferior nerve crosses from the lingual to buccal side of the mandible, often by the first molar. It is located in the midway between the buccal and the lingual cortical plates of the bone. Inferior nerve divided into mental and the incisive nerve in the premolar region. The mental nerve emerges from the mental canal and anterior to the mental foramen, and the mandibular canal is referred as the incisive canal. This is the anterior loop is the mental branch, in which the inferior neurovascular bundle gets divided into mental branch and the incisive branch. The mental foramen and nerve. The commonly 3 nerve branches of the mental nerve emerge from the mental foramen. They supply innervations to the skin of the mental foraminal area, the lower lip, chin, mucous membrane, and the gingiva until the second premolar. The anterior loop of the mental foramen refers to the inferior nerve when it courses inferiorly and anterior to the foramen, and then it loops back to the emerge from the loop. Several methods and techniques of the identifying the extent of the anterior loop of the neurovascular bundle have been proposed using panoramic radiographs, computer tomography, and the determination of AL during the surgery using a curved explorer. If placement of the probe into the mental foramen on the distal side reveals the mental canal is patent and the anterior loop is not present. If placement of the probe into the mental foramen on the distal side reveals that the mental canal is not patent and the anterior loop of the mental nerve exists, the nerve must have transversed inferiorly and looped back to the foramen, creating an anterior loop. Mandibular incisive canal. Numerous investigations report that there is a true incisive canal basally to the mental foramen, in which the continuation of the mandibular canal. Incisive nerve supplies innervation to teeth, that is first bicuspid canine and later the central incisors. The incisive canal is typically found in the middle third of the mandible. It is usually narrows as it approaches the midline and only reaches in the midline 8% of time. The nerve usually terminates apical to the lateral incisors, sometimes apical to the central incisor. The lingual foramen lateral canal. The vascular canals are often present in the midline and lateral to the midline of the mandible. The lingual foramen was detected in 99% of mandibles when involving the skull dissections. The lingual foramen harbors the artery that corresponds to anastomosis of right and the left sublingual arteries. Submental and sublingual artery. Submental artery, this 2 mm average of diameter, is derived from the facial artery, and the sublingual artery is a branch of the sublingual artery. The sublingual artery is found above the malleolar muscle and is the major nutrient vessel in the floor of the mouth. Submental artery frequently transverses inferior to the malleolar muscle. Hofstadter et al. Also reported that sublingual and submental arteries may course anteriorly in close proximity to the lingual plate, and branches of these blood vessels enter accessory foramina along the lingual cortex. Inadvertent penetration through the lingual cortical plate into the floor of the mouth while preparing an osteotomy can cause arterial trauma, thereby resulting in the development of sublingual and submandibular hematoma. Submandibular and sublingual fossa. These submandibular fossa is a depression on the medial surface of the mandible inferior to the malleolar line, and it contains a submandibular gland. The sublingual gland is found in the sublingual fossa. This fossa is a shallow depression on the medial surface of the mandible on the both sides of the mental spine superior to the malleolar line. The submandibular and the sublingual fossa must be palpated prior to osteotomy development. If there is a large undercut and the lingual bone plate can be perforated inadvertently, resulting in the hemorrhage. If there is a large undercut, an instrument can be placed parallelly into the undercut and visualize and measure the extent of the fossa. The lingual and the myrohalar nerve. The mandibular branch of trigeminal nerve gives rise to the lingual nerve. This nerve provides sensory innervation to the mucous membrane of the anterior 2/3 of the tongue and the lingual tissues. At the time of implant surgery, in the posterior mandible, the lingual nerve can be injured if the lingual flap is not reflected cautiously. The lingual nerve is usually located 3 mm apical to the osseous crest and the 2 mm horizontally from the lingual cortical plate in the flap. However, in 15 to 20% of cases, the nerve may be situated at or above the crest of the bone lingual to the mandibular third molars. The bilateral nerve is a branch of inferior nerve. It arises just prior to where the inferior nerve enters the mandibular foramen. On the deep surface of the ramus, it moves down in a groove to reach and innervate the malleolar muscle in the anterior belly of digastric. Long buccal nerve. Long buccal nerve is a branch of the mandibular nerve that is derived from the trigeminal nerve. It begins high in the infratemporal fossa. It transmits sensory information to the buccal gingiva and mucosa of the cheek. The muscle attachment attached to the mandible. There are 26 muscles attached to the mandible. There are 2 single muscles and 12 pairs of bilateral muscles. The 12 pairs of bilateral muscles are digastric, bedcenter, depressor anglo-ovale, depressor labii-inferioris, genea glossus, genea hyade, masseter, mentalis, mylohyoid, lateral pterygoid, medial pterygoid, and temporalis. The mentalis muscle, mylohyoid muscle, genea tubercles, depressor anglo-ovalis, depressor labii-inferioris, vaccinator, or orbicularis oris muscle, and masseter muscle. The mentalis muscle is a paired muscle. Paired small muscle that originates in the incisive fossa of the mandible and inserts into the integument of the chin. When a flap is raised in this region, and the entire mentalis muscle should be released off from the mental protuberance because the muscle may fail to reattach well. This can result in an appearance referred to as a pitch chin. The bilateral muscle, the 2 flat bilateral muscles from the sling inferior to the tongue supporting the floor of the mouth, they are Their origin is the malar line on the medial aspect of the mandible, which extends from the superior symphysis to the last molar. This muscle is an important anatomical barrier separating the sublingual and submandibular spaces. The submandibular fossa is below the malar muscle and the sublingual fossa superior to the muscle. The geniotubercle. The geniotubercles are small bony elevation located on the lingual surfaces of the mandible. They are found on the either side of the midline close to the inferior border of the mandible. There are two superior and two inferior tubercles. The genioglossus originates from the superior geniotubercles and the geniohyadma originates from the inferior geniotubercles. The depressor anguloris and the depressor labioinferioris, these two muscles that overlay the mental foramen, need to be displaced when exposing the roof of the foramen. Once the flap is elevated past the mucogingival junction, these muscles can be released by using a wet gauze to push back the flap. The wet gauze is used to protect the mental nerve. Buccinator and the orbicularis oris muscle. The submucosa is strongly attached to the buccinator muscle in the cheek region, and the orbicularis oris in the lip area. Masseter muscle consists of two portions, superior, superficial and deep. When the mandibular ramus area is used as a donor site for bone grafting, the part of masseter muscle is released from the ramus when the periostem is elevated in this region. In the maxillary sinus and inferior alveolar canal are the principal anatomical sites limiting the implant placement. Basic surgical procedure of implant. Implant placement. Two-stage surgical protocol and single-stage surgical protocol. Two-stage surgical protocol. The original protocol for placing a modern osseointegrated implants was two-stage surgery, and it is still widely used today. The implant is placed below the soft tissue and protected from the occlusal function and other forces during osseointegration. The low-profile two-stage surgical protocols in which the low-profile cover cap is placed on the implant to protect it from the increase of soft tissue. The following osseointegration, the second stage exposes the implant and transmucosal healing abutment placed to allow the soft tissue healing development of sulcus. The prosthetic restoration begins after the soft tissue healing. Single stage surgical protocol. Single stage surgery leaves the implant or abutment connection exposed to the oral cavity via integrated transmucosal element or an removable healing abutment. This eliminates the need for second stage surgery to expose the implant. Although the implant is not an occlusal, some forces can be transmitted to it through the exposed transmucosal element. The prosthetic restoration begins following the osseointegration of the implant and soft tissue healing. Non-functional immediate restoration. The single stage surgery with the non-functional immediate restoration provides the patient's non-occlusal provision process early in the treatment plan. An abutment may be placed on the implant at or short after the surgery. A provisional restoration is secured with the temporary cement. Alternatively, the screw retain process may be fabricated. The provisional can help contour soft tissue profile during healing. The immediate function restoration. The single stage surgery with the immediate function is possible in good quality of bone, where the multiple implants exhibiting excellent initial stability can be splintered together. The splinting implants together can offer a significant biomechanical advantage over the individual unsplinted crowns. The following items require hand tightening, which can be approximately 10 Newton per centimeter. Surgical cover caps, healing abutments, cover caps for the abutment, for screw, and all impression connecting screws. The successful implant placement release and the adequate bone quantity and quality. The availability of bone at the implant site is based on the many principles. Some of the principles controlled by dentist include the atraumatic extraction techniques, preservation of a bony socket, selection of interim process, the timing of implant placement. The implant placement, the patient preparation, soft tissue insertion, preparation of implant site, and implant placement. Patient preparation, preoperative antibiotic prophylaxis is usually recommended. Profound local anesthesia is required for the precise implant placement. The patient can rinse with 15 ml of 0.12% of chloroxine gluconate for 30 seconds immediately before the start of the surgery to reduce the oral microbial count. Soft tissue incision, several types of incision can be used to gain access to the residual ridge of the implant placement. The incision should be designed to allow the convenient traction of the soft tissue for unimpeded implant placement. It should preserve or increase the quality of unattached tissue and preserve the local tissue aesthetics. Preparation of the implant site. After the bone is exposed, the surgical gate template is positioned and a preliminary assessment of the implant site is made. The residual ridge may have the areas of unevenness, sharp ridges that are best reduced with the ronger or a burr before drilling for the implant placement. The fibroosseous tissue should be removed so that it will not be incorporated to the implant site. The placement procedures for the all implant systems require atraumatic preparation of the recipient site. A low speed, high torque handpiece and a copious irrigation are necessary to prevent the excess of thermal injury to the bone. The bone is exposed. The surgical template is positioned. All the implants have an initial small diameter drill that is used to mark the implant site. With that initial drill, the center of the implant recipient site is marked and the initial pilot hole is prepared, and the implant recipient site preparation continuously drilling with a series of gradual large burrs. The implant placement after the desired depth and the diameter of the recipient site, the site is accomplished and the implant is placed. Although some implants are pressed into the place, the most are threaded. Hand must be screwed in place by the handpiece at a very low speed or by hand. The final tightening in most of the cases is done with the hand with the ratchet. After all implants are placed, the wound is closed. Post-operative, the radiograph should be taken post-operative to evaluate the position of the implant in relation to the adjacent structures such as sinus and inferior canal and related to the other implants. The patient should be provided analgesics. The patient can also be instructed to use the 0.12% of chloroxine gluconate rinse for 2 weeks after surgery to helps to keep the bacterial population the minimal during healing. The patient is evaluated weekly until soft tissue healing, wound healing is complete. If the patient wears a tissue-bound denture over the area of the implant, the denture can be relined with a soft liner after 1 week and may be worn. The interim partial dentures or orthodontic reliners with an attached pontic may be worn immediately but must be countered to avoid the soft tissue loading. Prosthetic stage. After 3 to 4 months, a second stage surgery, the implant site is reopened. Cover screw is taken out. The gingival form is fitted on the implant screw for 1 week. In one stage implants, the cover screw and gingival form are not rugged. As we don't directly go for the prosthetic work just after the insertion of the implant in the bone. Thank you.